Are you ready to share your medical surgical expertise?
Do you have an exciting research project or innovative solution you want to share with your peers?
Now is your time to shine. Submit an abstract to present at the 2025 AMSN Convention in Austin, Texas, September 11th through the 13th.
Whether you have valuable insights, innovative practices, or compelling case studies, we want to hear from you.
To be considered, submit your abstract by Friday, January 10th.
To learn more, visit www.amsn.org.
On this episode of med-surg Moments,
you've got this sensory component, that physiologic transmission of pain signals. That's the sharp stabbing or throbbing pain after an injury or with a chronic condition like arthritis, or maybe the burning and shooting pain that you would get after an amputation. So these are all sensory components, physical components. But there's this whole other layer of emotional component that I think is not really considered, but actually explains a lot of the variability between people. I suppose you could give enough opioid to make somebody's emotional suffering go away, but probably not recommended. So when you think about that, what are we doing for people's pain? When you go into a room, somebody's having pain for whatever reason, and we intervene, we're not often addressing the emotional suffering component. So the physical, the emotional, thinking about why these pain experiences in individuals are so different is a part of it. And when I talk about this idea of a tool, a secret tool, it's truly...
This is Eric,
Mary Tess,
Sydney, Sam,
Neil,
and Laura. Welcome to med-surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud med-surg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
As med-surg nurses, one of the most difficult struggles we face in caring for our patients is pain management.
While our training and experience has given us the required knowledge about pain physiology, assessment techniques, and treatment modalities, there is a secret tool we often overlook.
Beyond pain scales and medication, this secret tool completes our ability to do all that we can do to alleviate our patients' suffering.
Here with us today to talk more about this secret tool is Dr. Michael Urton. Dr. Urton has been a medical surgical nurse and thought leader for nearly 25 years, working in a variety of inpatient, procedural, and ambulatory clinical settings.
He served in the U.S. Navy as a Nurse Corps officer, retiring with 22 years of service at the rank of Lieutenant Commander. Presently, Mike is an Adult-Gerontology clinical nurse specialist in North Carolina and director for advanced practice nursing at Duke University Health System.
Over his career, he has developed a passion for patient safety and for acute and chronic pain management. Mike, welcome to med-surg Moments.
Thank you, everybody. I really appreciate that wonderful introduction, and I'm excited to meet the group and share a little bit of what I've learned over the years about pain management.
Mike, before we get to that secret tool, our listeners would love to hear the story about your journey into nursing.
When I was younger, I enlisted in the Navy. Straight out of high school as part of the Navy's nuclear power program. I worked with electrical systems for nuclear reactors, and I loved math and science and engineering and had nothing to do with healthcare. And after a few years, the Navy was going to send me back to school and get my commission and get my degree, and they gave me a couple of options, and one of those options was in nursing. They were pushing to have more men in nursing, problem we still have even today. Having a family at that time, I was looking for something that might not send me all over the world. So nursing was it. I knew nothing about it, and I got into it. And what I found really quickly was the things that I enjoyed about engineering, the math, the science, the problem solving, all of that stuff was present in healthcare as well. And really kind of just took hold of it and enjoyed being in the hospital, enjoyed working with all the different patient populations. And what I found was it wasn't that different. The only major difference was my patients talked back to me, where My equipment didn't. So sometimes that was a good thing. Sometimes that was a bad thing. But that's definitely what kept me excited about nursing all these years.
So, Mike, what is it about pain management that really caught your attention?
Originally, it was the prevalence of it and the problem-solving aspect of it. I mean, every one of our patients have pain. It's the part that I think most nurses struggle with, certainly early in my career. It just never goes away. And no matter how you came to nursing, you ultimately want to help the people that you're working with. And I always found that the pain management part of it was one of the things I felt most helpless about. So I just started trying to learn a little bit more. And again, since I like solving puzzles, that felt like the ultimate one. It's so complicated. There's inequity and bias built into it. And it just kept drawing me on. Every place I went throughout my career, I got more and more involved in it. As I went back to school and became a clinical nurse specialist, focusing on health systems and length of stay and all these other problems that exist when we were trying to improve patient care, it just kept on growing. And I started getting more involved in acute and chronic pain and substance abuse disorder and all of those pieces that came into it. It's just been such a universal thing. Everywhere I go, it's a challenge for patients. It's a challenge for their families. It's a challenge for the nurses. Let's face it, there's nothing that can ruin a shift and just kind of make you have a rough night than having a patient that you can't get their pain under control. And then you get stuck in the middle of the patient and the family and the providers, and you're just trying to do your best. That's just brought me to wanting to learn more and more about it.
Given your expertise, why do you think pain management is so challenging?
It seems simple, right? Someone's in pain, you measure a score, you go get your meds, and it makes it all better and problem solved. You give them some medication, some ice, maybe you position them, it's done. We've been researching pain forever. The first pain medications were related to aspirin 3,000 or 4,000 years ago. It feels like we should have it all figured out. But that's just not the reality. I think we all know that it is not simple. It is not easy, despite what our order sets make it look like, despite what the pain scales make it look like. You know, you've got the 0 to 10 scale and, oh, it's so simple. It's either mild, moderate, severe, and we treat it. But we know it's not that case. Most people have heard the phrase, pain is what the patient says it is. It's a super simplistic phrase, but I think the sentiment is key about why it's so challenging. And that's that it's subjective and it's complex. Every patient experiencing pain is different for a lot of reasons, both physiologically, emotionally, mentally, psychology, culturally. And because of that, you can have two people with exactly the same trauma, exactly the same surgery or the same injury, but have wildly different pain experiences. Unfortunately, our order sets and our guidance from our providers rarely takes that into account, that variability. Matter of fact, it frustrates us. It makes us almost get upset with the patient because they're not following the plan that should be happening after their appendectomy or after their knee replacements. And we put that burden back on the patient as if they've done something wrong. We don't have enough time to dig into that subjectiveness, unfortunately. And so that makes it challenging. And even the interventions that we have so many of them. We have medications and non-pharmacologic interventions and behavioral health treatments. And now we've got a lot of other alternative treatments, but none of them are really as well understood in terms of efficacy and safety as we think they are, as we thought they were. And so I think all of those things contribute to that challenge. Again, it's the part that I enjoy. It's the part that excites me when I'm able to consult with a patient and hopefully get to a positive outcome. But at the bedside and as having been a patient at various times, it drives me crazy that we just can't get it right sometimes, no matter how much we try. It's all of this. And there's things we haven't tried. There's things we haven't considered. And my passion and mission over the years has been to break free from what we think we know and what we're taught in school about the basics of pain management and the way that we assess it and the way that we intervene with it, and recognize that there's more to the puzzle that we're just not thinking about when we're at the bedside, when we're standing in front of the patient.
Mike, you were one of the most popular speakers at this year's AMSN convention. One of the things that really captured our attention was your explanation of something we thought was so obvious. What is pain, and what can you tell us about the secret tool for pain management?
Pain is a physical symptom, a sensory component. Some people learn a little bit more about how the pain receptors work and how they transmit through the peripheral nervous system and then up to the central nervous system to the brain, how it's processed. But it's very focused on the physical sensory component. And yes, we know that there's some variability that we've talked about, but that's background noise. It's not super important. The main part is the physical piece of it. And it was only later in my career, as I started working with patients more, that you start thinking about the emotional component of pain. One of my mentors described this as the difference between hurting and suffering, with suffering representing that non-physical element of pain. You've got this sensory component, that physiologic transmission of pain signals. That's the sharp stabbing or throbbing pain after an injury or with a chronic condition like arthritis, or maybe the burning and shooting pain that you would get after an amputation. So these are all sensory components, physical components. But there's this whole other layer of emotional component that I think is not really considered, but actually explains a lot of the variability between people. Some of the variability certainly comes from the sensory, the differences that we all have physiologically in our nervous system. But there's this huge part that it's about the emotional component. And I'm not talking about kind of psychological differences and how we may have had various conditions in our past that influence things. I'm talking about the emotional pieces that go into living as a human. Every pain condition has this emotional component that we're not really thinking about. It's the suffering part of it. And it's not driven by pain pathways. It's often not affected by most of the treatments that we approach our patients with, which is why if you're not addressing that piece of it, it feels like you're not succeeding. I suppose you could give enough opioid to make somebody's emotional suffering go away, but probably not recommended. Probably going to have some pretty serious effects that we don't want to mess around with. So when you think about that, what are we doing for people's pain? When you go into a room, somebody's having pain, for whatever reason, and we intervene, we're not often addressing the emotional suffering component. Frequently, we're not even asking about that piece of it. We're just kind of moving in and out of the rooms on our way. So I think this piece of it, thinking about the emotional aspect of pain, is a key element. And just for some examples, I want you to imagine that you have somebody who 3 years ago, they were treated for some kind of cancer, maybe a bone cancer, and now they're having pain in that leg again where they had that bone cancer. They were treated, they went into remission, all was good, and now we're 3 years into the future. They're having pain in that same area, and all they can think about is it's come back. So the pain they're experiencing certainly may be from whatever might be going on in their leg, but there's this whole other layer to their pain that is much more about the emotional pieces that go into that. I had a patient a few years ago when I was working in the acute pain service, came in with a fracture to their leg and could not get their pain under control. The staff and the primary team, they were everything they possibly could. Every opioid you can imagine, patient-controlled analgesia, this just over and over and over again, and everything they did had no effect. Myself and the anesthesiologist that we were meeting with that patient came in and started talking to her a little bit more, and we hadn't been aware that she had had this history of cancer. And was in remission, and all that she was thinking about was that she was going to lose her leg. She was told if it came back, they would probably have to amputate her leg at the hip, and that's what she was focused on. Once we started exploring that, once we were able to get the films that were needed to confirm that that wasn't what was going on, it changed everything. 12, 14 hours later, almost every opioid had been completely discontinued. Her pain was managed with acetaminophen and ibuprofen. If we had kept going, would we have overdosed her potentially? Who knows what path we would have put her on because we just weren't asking the right questions. What we were asking her is your pain still 10 out of 10? Is your pain still 10 out of 10? And it was. But what we weren't really exploring was where that pain was coming from. Was it really the leg? Was it the bone? Was it the hip? Or was it just she was suffering and we weren't really capturing that? That suffering was not being treated by the fentanyl or by the Dilaudid or any of the other things that we were giving her. even more minor things, it's easy to kind of discount it and other things. But if you have somebody with a knee injury and they've spent their life as a runner, that is traumatic to them. There is a tremendous amount of suffering that goes in to somebody who may not be able to live their life the way that they want to, even if it doesn't seem important outside of their life. And so that's kind of this emotional piece that I think we miss. So the physical, the emotional, thinking about why these pain experiences in individuals are so different is a part of it. And when I talk about this idea of a tool, a secret tool, it's truly the empathy and compassion that you bring to this encounter. Every nurse probably thinks of themselves as highly empathetic and compassionate. And I think there's probably a lot of truth to that. But I don't know that we let that come through with our interactions with our patients and the way that we go about our shift. It's so easy to get drawn into the task list and to make it from one item to the next item, to the next med pass, to the next assessment, to the documentation, and on and on and on, and forget that there's a person lying in that bed that needs that genuine connection that comes from an empathetic and active listening approach. And that empathy and compassion is the piece that I find makes my pain management far more successful than when it wasn't front and center with the way that I approached pain, which was kind of the traditional method. You assess it, you get a number, you give a drug, you move on, and so on and so on.
Can you tell us more about what empathy is in pain management and how does it come into play?
Yeah, we throw that term around, empathy and compassion. They're often used interchangeably. They're slightly different. Both of these terms really describe the desire to understand somebody else's emotions and, where possible, to alleviate that distress. Now, I think we'd all say that we have that, right? That's why we're nurses. That's why we take care of patients, because we want to alleviate distress. But I do think that that effort towards understanding emotion is the piece that can get lost in the shuffle. I don't think it's not important, but I do think that it can get lost. We all have a degree of empathy for others. And I think nurses tend to have greater empathy than the general public, which is why we're doing what we're doing. And it's more than sadness or pity for another suffering. It's taking action. It's easy to listen to the woes of somebody else and say, oh, that's too bad. But I think what separates that from empathy and, more importantly, compassion is the step that you then take to make it better. Sometimes we're doing that in little ways when we see that a patient is lonely and we find a few minutes in our shift to listen to them or ask about their family or understand about their career when they were younger. And I suppose you could manage pain without taking an empathetic approach. You could give the drugs that are ordered and maybe it would turn out okay. I don't mean to say that without empathy, there is no effective pain management. Where it becomes critical is in any kind of complex pain management, whether it's think chronic pain, think multi-pain. So I've got back pain for 25 years, but now I also have a new appendectomy. And also I have this arthritis in my right knee, and all of them are flaring up in different ways. And I don't quite understand how it's all impacting that patient. That's the kind of pain that lacking an empathetic approach to that patient and that conversation can make it very, very difficult to be successful. And I see this all the time, that when you have multiple types of pain, complex combinations, that we might do a very good job managing that acute pain following a surgical intervention or dressing change. And at the same time, that patient is struggling in all kinds of different ways. But we don't often ask those questions or try and explore that other pain that patient has going on. It's almost a hassle because I've got to get on to the next thing. And this is the puzzle. This is where we're trying to piece all these things together and figure out, what do we do? Back to nursing school, right? Assessment, diagnose, plan, implement, evaluate, that ADPI that many of us learned. The part that's missing is the really good assessment. We're screening, we're measuring, we're asking some questions, but what I found is that we're not fully asking the questions, which means that our plan is often less than. It's a little bit inadequate. We go ahead and implement it. But again, since we failed a bit on the assessment part and we failed a bit on the plan part, our implementation really only has a 50-50 chance of success. And sometimes we get lucky and we solve it, we get it. But often we don't, especially in the more complex situations.
Such a great explanation. I come from the oncology world and I do a lot of education with regard to palliative care. And I think in that aspect, we talk a lot about that concept, that total pain concept, where we try to take into account that emotional component. But again, that's strictly for those patients that are nearing the end of life or have those chronic conditions. We don't often think about that in everyday pain situations that we might see on the floor. So thank you for bringing that up. This has been really, really helpful. But putting that concept into practice, how do you suggest that we use empathy to help manage our patient's pain, like at the bedside?
There's the catch, right? Because every nurse at the bedside has so much free time.
All the time in the world.
Exactly. When I go in to see a patient, 20 to 30 minutes is pretty typical for a consult. I'm not actively doing consultation now, but that was pretty typical. However, I think there's ways to do this. So as with every complex problem, there's no one size fits all. And empathy certainly is not going to make your patients pain-free. You're using it as a lens to do the things that you're already doing, to be able to get the information more fully from the patients and build a relationship with them that results in a trust that you won't have without it. And I think this is kind of the way that it gets pieced together. There are dozens of pain management interventions. So everything from kind, encouraging words, though most people wouldn't think of that as pain management, but it absolutely is. Being supportive, being caring, being present is a form of pain management, to all of the medications that we have and even more complex surgical interventions. But every one of these interventions comes with a risk and a cost. And part of what our job is to figure out, along with the medical team, it's not all on the nurses certainly, but what is the right combination of things that we can help the patient as fully as possible to accomplish their goals. Those goals may be comfort, those goals may be functional, some combination of those, but to understand that and build that plan. And the assessment piece with an empathetic lens is where that comes into play. Now, where I think this looks at the bedside, it can be anything from when I talk to the patient about a pain condition, one of the things that I'm doing is certainly asking them the things about where's your pain, how long it's been there, or how severe. Those are fundamental questions. Some of the questions that don't get asked is, how does this affect you? What does this mean to you? How is this relative to normal? How is this impacting you functionally? Is it impacting your relationships, your mood, your sleep? And some of these seem silly, like it's far more important with chronic pain conditions. But honestly, in the hospital, the chronic pain conditions are the ones where we fail the most. And because we fail on the chronic pain, it makes managing the acute pain more difficult to manage. So this is where that comes in, the way that we ask the questions. So when we talk about empathetic approach, it is things like active listening, even if it's for 60 seconds, sitting down while talking to the patient because you're present. That presence, that active listening, that validation to what people are saying, it's these things that can be done even in minute increments throughout the day that don't add a tremendous amount of time, but still become more meaningful. It allows the patient to open up. It allows them to be more forthcoming about what's going on so that you can make sure that the things that you're communicating to the physician or with the pain management plan make sense in a way that you want them to. This functional piece, it's something that is really left out of a lot of our conversations. And it's related to the empathy because, again, it's trying to understand what the pain situation means for that patient rather than thinking about what it means for us. An example of that would be the patient might report a 9 out of 10 severe pain, but not wanting anything for it because they're actually doing fine and they don't want to aggravate anything. Or they might report a 3 out of 10 and they really do need some kind of intervention. So it's easy to get caught up in the pain severity and miss out on the implications of that pain for the patient. The final thing I think that these brief encounters with patients with an empathetic, compassionate approach bring is a level of consideration and respect for the patient's experience that is easy to lose in all the running in and out of the rooms. Patients lying in that bed, it is so easy for them to feel like nobody really cares what's happening to them. Everybody is caring for them, but that's not the same as caring for them. I want my patients to believe that I care what is happening to them so that when I come back to them and say, I know this sounds crazy, but here's what I think you need for your plan. And here's why this acetaminophen is actually a better option for you than these 10 milligrams of morphine. There's got to be some trust built up there for them to get on board with that plan. And that empathy, that relationship that you're building with the patient is what gets you there. It pays dividends down the road for every other encounter, but from a pain management standpoint, it allows you to be much more effective in the way that you're approaching things and the way that you're trying to get the patient over the finish line in terms of their successful pain management.
I have a lot of experience remembering getting patients ready for discharge where they're getting the IV pain medication after their procedure, and we're trying to get them ready to go home. So we want to switch them to medications that they're going to take at home. And sometimes that can be a struggle with patients who are afraid of the pain and they don't want to switch from that IV to the oral medication, and it can delay their discharge.
This is one of the pieces that we aren't always the best at as healthcare systems, whether it's diabetes or pain or anything else. From the very beginning, we're taught that we should be thinking about discharge from the beginning. We know that's often not the case because, again, we're doing a lot of running around. Pain management is no different, and you're absolutely right. No matter what setting I've been in, and I've worked in acute care and rehab and ambulatory, it's almost always the same, that it's an afterthought about what that transition is going to look like for home. When we approach their pain management at every stage, on day one post-op or on day one of admission, or whether it's day 5 or the day of discharge, when we approach it with this goal of understanding what's going on with their pain, what that pain means to the patient, and how it's affecting them, it allows us to help drive their interventions or their plan in a way that's being thoughtful to the whole picture. And an example of that would be, from the very beginning, we see patients that won't end up staying on IV opioids longer than necessary because they feel like they need it. They feel like their pain is severe and it meets our criteria. So as a nurse, I give those IV opioids that I'm able to give, when really that may not be what's needed, both for the patient or for the hospitalization, because we do know there's an endpoint, there's a discharge. By trying to understand what's going on, be part of that relationship, build that partnership with the patient so that they understand where we're trying to end, where we need to get them to, then you can help drive that and then have those conversations with the physicians if there's orders that are lacking. But again, think about how hard it is with no connection to that patient, with no relationship to that patient other than you're their nurse. And now you're asking them to take what they view as a lesser treatment. Why would I agree to that? That doesn't sound fun at all. No, I want the stronger stuff. And I don't trust you because you're not my partner here. That's what the empathy and the compassion, when it's genuine, when it's honest, it allows you to connect with that patient. When I worked in inpatient rehab, one of the populations I worked with were people who just had back surgeries. And so they would come in 1 to 3 weeks of inpatient rehab. And these are people who had spine fusions and all kinds of things like that. Frequently had been on opioids forever. Opioids for back pain is one of the biggest no-nos these days. We know it has no benefit. The literature is so strong. But again, these patients were put on opioids 20 years ago and have just been maintained. And so you'll have people who are on just ridiculous amounts of opioids, and they have no impact on their functional outcomes. Higher opioids don't change anything about how they can work or whether they can move. Number of patients that I would see them and talk to them and say, here's kind of what I'm thinking. Here's what we're doing. Let's back off on these opioids and just see what happens and give it a day. But it was after building that relationship that you would get this trust of like, okay, we'll give it a try. And it was really surprising how many people we could aggressively cut. I could have somebody who was on 80 milligrams of oxycontin twice a day at the start of their hospitalization and be down to 10 twice a day at the end of their hospitalization 2 weeks later. And when I'd ask them, is your pain better? They told me, nope, it's not any better. But they can do all the same things. They can still move, they can still sleep, they can still get up and walk, they can talk to their grandkids. And that was what I was working them towards, is trying to understand what they wanted out of their pain management and recognizing the pros and cons of all the different interventions. But again, without having that relationship, without building that trust with them, there's no chance that we were going to be successful there and get them to where they needed to be. One gentleman, he came back a year later, he had another back surgery, and he told me shortly after that first hospitalization, he'd completely come off all the opioids and hadn't been on them for the entire year. He had his surgery, and I think he was on just a little bit of oxycodone for a day or two and then got off. He's like, well, I learned it doesn't help. I wish I felt better. I wish I didn't have that pain, but he at least learned that the opioids weren't having the impact that he had always thought they were. It's helpful thinking about that, and it's helpful driving that. But the key part of the empathy and compassion is it puts you in a position to be more successful at having those conversations with the patient and help guide them towards the endpoint that you know that they need to have, which is not on IV, maybe not even on oral opioids, and being able to self-manage with over-the-counters, which is often where we are with most of our patients that we send home these days.
Is there any research being done or studies currently being conducted that links empathy with positive patient outcomes?
There is not. I looked long and hard, and I thought for sure I would find something. I don't know if it's that it feels so obvious, that it's so hard to do the research. When I was preparing for my presentation this past September, I kept looking for literature. I'm like, there's got to be something out there. And I would find a random article in Southeast Asia or in Europe, but they were really poor studies. They really weren't even looking at what I was thinking about. Or you'll see things that talk about empathy and compassion, burnout, see things talking about physician empathy and compassion, but not in terms of specifically efficacy in pain management. So clearly an area that in my tremendous free time is an opportunity to go dig deeper in. This is all Mike saying it works and going on faith, I suppose.
Well, if there's anyone to speak on it, it seems like it's you. Mike, you've given us so much to think about, and it's truly been an inspiration having you with us on this episode of med-surg Moments.
Thanks, Sydney. It's been great being here. I've enjoyed talking about this, and as my friends will tell me, I always have lots to say on the topic, so I'm happy to come back anytime.
To our listeners, be sure to check out the show notes for this episode, as we're going to drop a link to Mike's presentation from this year's AMSN annual convention. Thanks for joining us. We'll see you next time. We look forward to connecting with you on the next episode of med-surg Moments, the AMSN podcast.
In the meantime, we encourage you to subscribe to med-surg Moments wherever you listen to podcasts.
To reach us, use hashtag med-surg Moments on your social posts.
Or send us an email at amsnpod@amsn.org. That's amsnpod@amsn.org.
We're all AMSN members, and if you love med-surg Moments, we invite you to become a member of AMSN. You can learn more at www.amsn.org.
Finally, the content within the med-surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses.
Until next time, this is Eric,
Laura,
Mary Tess,
Neil,
Sam,
And Sydney. And always remember, med-surg Moments is a moment in our lives and a moment in our med-surg careers that makes a huge difference.